Good morning, everyone. We're just going to take a quick minute and let folks get into the Zoom room, and we will be starting momentarily. All right, good morning again, and welcome to Collaboration for High Quality School Mental Health Services, effective partnering with external service providers, with our presenters, Dr. Miranda Zahn and Dr. Stephanie Campbell. This webinar is co-sponsored by the Great Lakes MHTTC and SAMHSA. The Great Lakes ATTC, MHTTC, and PTTC are funded by SAMHSA under the following cooperative agreements. The opinions expressed in this webinar are the views of the speaker and do not reflect the official position of the Department of Health and Human Services and SAMHSA. The MHTTC network believes that words matter and uses affirming, respectful, and recovery-oriented language in all activities. A few housekeeping items. If you're having any technical issues, please message me, Jen Winslow, or Alyssa Quala in the chat section, or Rebecca Buller, and we will be happy to assist you. If you have any questions for the speakers, please put those in the Q&A section of your Zoom toolbar. It helps us keep them organized if the chat starts moving quickly. If captions or live transcript would be helpful, please use your Zoom toolbar to enable them by selecting Show Captions. At the end of this session, you will be automatically redirected to a very brief survey. We greatly appreciate you taking just a moment to fill that out. Certificates of attendance will be sent out via email to all who attended this session in full. Please allow up to 2 weeks for those to process, and also keep in mind if you don't see those certificates to check your spam or junk mail. The recording will be available on the Great Lakes MHTTC website within a week following the presentation. You can currently find the PDF of the presentation slides as well as the resource guide on that same webpage we will put into the chat. For more upcoming events and information, please follow the Great Lakes MHTTC on social media or visit our website. And I would like to welcome our presenters. Miranda Zahn is an assistant professor of school psychology at the University of South Dakota. She conducts research, training, and technical assistance in school-based mental health services. Specifically, Miranda focuses on social justice and the role of teachers in school supports for youth mental health. In addition, Miranda is a school psychologist and school mental health provider at Nebraska's Educational Service Unit No. 1, where she provides direct services to youth as well as training and system consultation to schools. Dr. Stephanie Campbell is half Filipina, half mid-fat, cisgender daughter of an immigrant who grew up in a one-stoplight town in Arkansas. She currently serves as the crisis liaison and community trainer for the Hawaii DOH Child and Adolescent Mental Health Division. Dr. Campbell participates in systems-level interventions for statewide mental health crisis response and develops free training opportunities for community members and providers, including certification of new PC care providers. Dr. Campbell's research centers around minoritized identities and their influence on mental health. She's especially interested in how experiences of race, body image, and weight stigma affect the well-being of children and adolescents, particularly in relation to the implications of culture, socioeconomic status, power and privilege, and gendered societal expectations. Outside of work, Dr. Campbell enjoys cooking without recipes, consuming an absurd amount of podcasts and YouTube, ocean paddling, and jigsaw puzzling. Welcome to our presenters, and welcome to you all for being here. Thank you very much.
Good morning. We're so glad that you are here to join us today. And if you're in the Midwest, in sort of the Great Lakes MHTTC region and are in the middle of blizzards and 40 degrees below zero, I hope that you and your loved ones are staying safe and warm and inside if you can. Jen, thanks so much for introducing us. I'm Miranda Zahn. I currently work at the University of South Dakota. And you heard a little about me, and I'll let Stephanie say hey too.
Hi, I'm Stephanie Campbell. A big intersection I have is going to have to do with crisis and how schools and community intersect with that just because of my role, but I'm excited to chat with you today.
All right. So in order to sort of tailor what we talk about and where we focus our time a little bit to those of us, or to sort of the folks who are joining us today, we'd love to hear in the chat some information about you. We're interested in knowing your role, where you are in the world, and then what school community collaboration looks like in your setting. This could be you have a community therapist co-located in your school. It could be sometimes you get referrals from community mental health providers for school-based care. It could be that you're an outside provider working with schools. We're just interested in knowing sort of in what way you interface with school community collaboration. I'll give you a little time to pop that in the chat. I can chat a little bit more about my experience with school community collaboration while folks work on typing that in the chat. So I currently work as a trainer and systems consultant in some Nebraska schools, where we really work to bring together different community providers and folks within the school building to support youth mental health. I also previously held a position at the National Center for School Mental Health, and there I frequently, I worked as an outpatient provider that was co-located within schools, so I interfaced kind of with both sets of systems. It looks like we've got some folks chiming in. The school social worker, you have a school navigator contracted with a local mental health board. Okay, someone in Ohio who receives school referrals, so probably an outpatient provider, school psychologist. Okay. Usually collaborate with folks outside of schools. In Virginia, okay, you provide support to school students and families, outside providers. Great, so it sounds like there are a lot of folks who are who work outside of the school setting, who are sort of interface with the school setting, who be are here to learn more about sort of how these systems can collaborate, which is exactly what we're here for. So I'm grateful that you all found us and to be able to speak to some of hopefully what your needs are. So today we're going to move through sort of three main sections, learning objectives. First, we're going to identify the roles and functions of a variety of mental health providers, including within and outside of school systems. I know that this might feel a little elementary, but frequently we're really siloed in our systems. And sometimes we don't know sort of who else is out there, who else is providing services or supports to folks that may align with the needs that we're seeing or with our professional sort of collaboration. Then we're going to talk about some strategies to implement effective engagement for interprofessional care. So this will look like a couple pieces of sort of what that interpersonally can look like, but also what this interprofessional care can look like on a more systems level, the ways in which systems can interface with each other. And then we're going to talk about the legal and ethical requirements associated with school community collaboration. So talking about some of those privacy and confidentiality laws, how folks receive services in these different settings, and sort of how you can set up the folks that you work with to be able to access services in these different locations. So we're going to start with sort of the school-focused side of things. So school-based mental health services encompass a whole lot of things. We're going to get into sort of how outpatient interfaces with this, but first we're going to start with what really is in the schools, what already exists within a school building. So there are a lot of services and supports that can be provided in schools. We're going to talk a little bit about the different sort of mechanisms or pathways to receive those services. But here I'm going to talk just more broadly about the different services and supports that might be offered related to youth mental health. So in the school-based setting, we're most often looking at and providing supports for and understanding things like internalizing concerns, externalizing concerns, and learning concerns. So internalizing concerns include those things that we experience or that youth experience on an internal level, feelings that are inside of oneself that may be attached to sort of observable traits or observable characteristics or symptoms. These are things like depression, anxiety, and withdrawal. We also might look at externalizing concerns, which are those behaviors that are more outward in their nature. So things like attention, focus, aggression. In schools, we're also really interested in learning concerns and the ways that these maybe interface with student well-being and educational attainment. So this could include things like cognitive impairment and learning disabilities, which we also know sort of can coincide with some mental health disorders or needs. The really, really important thing to think about when we're talking about sort of what gets addressed in schools is this sort of fourth row educational impact. In schools, we're really frequently focusing on only those mental health behaviors or mental health and behavioral needs that have an impact on functioning in the school environment in some ways. Some areas and spaces define this more narrowly as what has an impact on academic achievement, really are sort of guiding law and things would say that that's not sufficient, but it is what's happening in a lot of schools right now. More broadly, schools should be, and many are, focusing on sort of broad well-being and functioning within the school-based environment. So this might look like the ways that students can interface socially with their peers in the school environment. This might look like the ways that students can sort of perform or, behave or feel comfortable during academic tasks. It could also mean, what it looks like for students to meet the sort of norms and expectations of the school setting. Usually, though, in the school setting, we're focused really on how a student shows up and has needs within the school-based context. That's for better or for worse. We're not always able to be the most child-directed because of competing demands and shortages. One of the primary ways that we sort of assess for that educational impact of internalizing concerns, externalizing concerns, and learning concerns is through an educational classification process. So this is often required for intensive or individualized services, but any educational classification that happens in the school-based setting is non-diagnostic. I'm going to go through on the next couple of slides what this really looks like. Outside of that formal educational classification, many schools and schools are newly adopting this every year. The reach of multi-tiered systems of support grows. Many schools are supporting students at all levels, right? So students who may develop risk in the future, students who maybe have a low level of need, but we can nip it in the bud and help them sort of get on a trajectory of long-term success before they might need individual supports, or as we are anticipating that a student might benefit from a more sort of introductory level of care. So school is a really great place for prevention, early intervention, and monitoring in those early stages of need, because we have them there 8 hours a day, 5 days a week, weather and blizzard closures notwithstanding. However, multi-tiered systems of support aren't universally implemented, so they are something that may exist in the schools that you work at or partner with, but they're growing and expanding, particularly in our areas of the country that are most affected by shortages. Oops. So the folks who are carrying out all of the school-based potential services include the folks on this list and other folks in a variety of roles. There are a lot of novel and interesting roles that have been adopted through grant funding and school system restructuring, but the folks that you can find in most schools or many schools are represented on this list. So first, we've got school counselors. These folks tend to provide classroom school counseling and social emotional lessons for all students. They can provide academic and career planning support and some short-term individualized counseling as needed. School psychologists are often really closely involved in that educational classification sort of process, and then also may provide services, supports, and consultation using data to inform interventions and needs throughout an intervention or eligibility process. They may also provide mental and behavioral health services and interventions. School social workers tend to function at a more universal level. They provide school-wide, small group, individual, and crisis interventions in many schools. They may implement prevention and early intervention and behavioral supports, and they may collaborate with community and family supports. And then school nurses tend to be involved in care coordination and health education, particularly as it relates to physical health and medical services, and the ways that those might show up in the school setting. It's important to note that these differ by state, and states have different rules about the ratios and who functions in these roles. I know in South Dakota, we have some ways that are different than my roles or the ways that I've interfaced with schools in Maryland and Wisconsin, where I was before. In the South Dakota model, which of course is unique to South Dakota, but may mirror some of the things you might see elsewhere, we have continuum of services, and this graphic put out by the South Dakota Department of Education, I think does a pretty good job of looking at the different layers of services that might be provided in schools and the different folks who may be involved in those types of care. So at tier 1, this is that universal preventative level that where all students may receive some services. Frequently, the folks that are involved in that are school counselors and school social workers. You'll see on the left and right-hand sides of this triangle. Those folks are most likely to be pushing into classrooms, working with all students on sort of a preventative level, and to sort of catch students who might need supports. Once we move to tier 2 and 3, we're looking at kids who maybe are at risk of some level of mental health or behavioral needs and supports in the school system. And tier 3 is those students who really need something individualized, customized to help them succeed and flourish. When we get to tiers 2 and 3, although school social workers and school counselors remain involved, we maybe switch a little bit more to school psychologists and community-based mental health counselors and social workers who might interface with the school setting. School psychologists tend to provide those supports or evaluations that will be relevant for the school-based setting. And then schools often at the tier 2 and particularly tier 3 level tend to make referrals or partner with outside agencies for needs that might be less educational in nature, but that require support. When we think about the mechanisms of support, of course, there's a movement towards MTSS and providing supports for any student who has a need in the school-based setting. But from a legal perspective, there are a couple of ways that schools are required to provide supports and services to youth who are in the public education system. So these two pieces of legislation really guide the way that services might be provided. The first is IDEA or IDEIA, the Individuals with Disabilities Education Improvement Act is the most up-to-date version. And then Section 504 of the Rehabilitation Act. These are both pieces of federal legislation that really inform the services that we provide in schools and lend themselves to that educational classification that leads to ongoing services and supports. So I'm going to go through sort of what it looks like for a person to qualify for services under IDEIA and Section 504, because these are really the ways that folks in schools can receive sort of protections and guarantees in some ways of services when they're found eligible. So it's important to note, particularly from an outside provider standpoint, that medical diagnosis or the rendering of some disability or label from the DSM or the ICD codes do not guarantee eligibility for services within the school-based setting, because the eligibility criteria go beyond sort of the presence of a disability. And really, we're looking at this sort of 3-question way of deciding whether a student needs services that the school is obligated to provide. So the first is the presence of a disability. This may be informed by, but is not solely sort of understood as the result of an outside provider's report. The presence of a disability can be evaluated within the school-based context by folks like school psychologists. Then folks on a school-based team look at the educational impact of that disability. This could mean an impact on educational attainment or sort of that achievement, test scores, whatnot, but really is the functional limitation in the school-based context. So this could mean ability to participate in the classroom environment. This could mean ability to benefit from social opportunities at school, ability to participate in leisure activities in the school-based setting, self-care, all of those things that might benefit, or that might sort of lead to a person's ability to participate fully in their education. And then the third piece is that a student needs specially designed instruction, related services, and/or accommodations in order to receive FAPE, which is a free and appropriate public education. These federal obligations within the school-based setting are really about a kid being able to participate in school, and that's sort of where obligation lives right now federally, although schools are moving towards providing supports for folks who may not fall into these categories. As we think about IDEA and Section 504 and the things that they provide, and the things that they obligate schools to serve, the ways that they obligate schools to serve students, particularly in mental and behavioral health, are outlined here. I encourage you to look back on this once you've got the sort of slides, because I'm not going to read all of this, but hope that it's a resource you can look back on. So IDEA is really the mechanism for special education. This provides services that are based on 13 defined disability categories in most states, that adverse impact on education, and specially designed instruction or related services. This tends to include things like the services of a special education teacher who can provide some supports and scaffolds in the school-based setting, like reinforcement and behavioral sort of supports. And it also includes related service providers like school psychologists, school counselors, school social workers, in their time to either consult with teachers on how they can provide supports that are mental and behavioral in nature, and or direct services to those youth. Section 504 may also allow for some accommodations. All right.
I'll mention too, actually, while you're on the topic of IDEA and 504, that for our community mental health friends, it's really important, I think, for staff, like care coordinators and folks, to understand these two, because even if you're not working in the school, it really affects the families we're working with, especially when the families themselves aren't super informed or educated about their rights and the difference between these. So I always really encourage, I feel like I do a lot of psychoeducation, honestly. I come from a school psychology background, so this is more in my wheelhouse than some community mental health providers, but it's really, really good for families to have this knowledge. And so having more people informing them, especially when schools might be able to offer different levels of support or different levels of information. A lot of schools are understaffed right now, especially. So it can be, the more people who have this knowledge, the better. Okay, so I'm going to talk about community mental health services and what those look like. So beyond, they offer a lot of the same supports as schools with the internalizing, externalizing, some of those different basic disorders, but there are also different topics that are more appropriate for a community-based setting. So one would be trauma, that's especially things that are complex and chronic. Community-based mental health providers have more time generally and can offer some more specialty care around trauma recovery and helping the family with all the fallout from that. I live in Hawaii, and we are still managing what's happening from post wildfires in August. And I think this is going to be something that's going to affect our community for years to come with the number of families who's been displaced. So there's a ton of extra education going on and a lot of opportunities for our community mental health providers to actually gain more skills and more evidence-based interventions to do with trauma, because this is one that's quite complex, right? In any case, even if it's just one acute case of trauma, that becomes a lot. Family functioning is another big one. That's something that's pretty difficult, if not impossible, to address in kind of your standard school mental health when it comes to communication challenges, behavioral management, especially with higher level care. So our kids who are using substances, the ones who run away, the ones who might need like a residential type treatment. Family functioning is also something that can be a lot more basic, right? It can be, how am I communicating with you in a responsive way? Different types of interventions are made specifically for that. Severe mental illness. And so this is not a exhaustive list at all, but some things that came to mind for me right away. Early psychosis, that's like first episode psychosis, typically will happen in teenage years or early 20s. And so in my state, we provide a program specifically for first episode psychosis between 15 and 21, I believe. And so they can get specialized care and a lot of course, education for the families as well on how to deal with that. Eating disorders is not typically something that's addressed in the school setting either. I think this is considered a very, among other things like OCD, a very specialized disorder where you need specialized training, specialized practicum to be able to understand and address that. And then things like personality disorders, I think they're more rare that they'd be diagnosed in children, but when they are, it's really important to have people who are a lot more well-versed in what that might entail. And it's not something that I certainly wasn't prepared for that as a school psychology trainee to handle personality disorders or even to assess for them. So it might be important just to get an assessment and an outside provider. And then there are co-occurring medical issues. So again, not an exhaustive list, but the things that came to mind right away, different types of neurological and seizure disorders. These would also be treated in the school, but they can't necessarily get the full treatment or the kind of scope of treatment you might need only in the school system. So families might need to benefit from a way to collaborate with their neurologist or to collaborate with other providers in the community that are caring for the kid. Tic disorders may or may not need some outside help. And then things with significant developmental delay that has like feeding concerns and some other things that would be addressed beyond just like a occupational therapist or physical therapist in the school. Okay, so what does it look like? I wanted to give just a little bit of history on this that is not necessarily outlined on the slide because I got curious too preparing for this of like, where did community mental health come from? Actually, the movement began in 1963 when President John Kennedy signed the Community Mental Health Act, and then a bunch of community centers popped up around the country. By the 70s, the programs really kind of narrowed their goal into really treating people with long-term and very highly disabling illnesses and trying to deinstitutionalize this population. So, I think we all kind of hear these horror stories of back centuries ago, and people would just be institutionalized and be kind of put away from society and not necessarily be treated very well because of the stigma against mental health. And so we're trying to reduce the population in that through some of the community mental health efforts. And then by the 1980s and 1990s, there are some big influences by the evidence-based practice movement and recovery movement, and that really influenced community mental health in different ways. But by the 2000s, at least in the United States, can't speak too much for other countries, but there's been a huge domination of having to control costs. And so unfortunately, that can have pretty significant impacts on the types of care and the way that you can care. And obviously, people work really hard to get around that, and we understand insurance systems, but there are things like fee-for-service systems, which we encounter a lot here with the providers that I work with. And fee-for-service is a way for providers to get paid without necessarily having them have the same securities as like a full-time job or a job where you're kind of an employee with the same types of benefits or ability to access a union or that kind of thing. And in some ways, I see that it creates a way for people to get care because we can have these providers to do that thing. But at the same time, we're not caring for providers in a way that can promote longevity. And I can't speak to other states, but I do know that fee-for-service systems happen all over. And in some places, I'm sure it works really well. In other places, I know it sure doesn't. So it really can vary a lot place to, just like schools, community mental health looks very different in different places. And so the different types of formats that are offered, the things that are the main things are outpatient. So those would be kind of your clinic visits that you would go to once a week or whatever amount of time. Inpatient, which for some folks, it is beneficial to have like a short-term stay in some kind of environment, maybe a hospital or other place. For example, eating disorder treatment centers are often inpatient units as well. And then residential care. So that looks like a specialized program for specific issues often, or a specific level of care. These are often a very high level of care. So some of our more intense behavior and emotional issues will go to residential. In our state, we have different ones for specifically like adolescents who have had like problematic sexualized behaviors, they'll have a special residential treatment center, or for youth who have had substance use related issues, they have a special residential treatment center. We actually have one specifically for girl identifying youth who have been sex trafficked or are at risk for sex trafficking. So these can look like a lot of different things essentially, but whatever the community has a need for, hopefully they'll have a way to access those different residential ones in your particular place. You know, where I live, it's a unique situation where we actually don't have necessarily all the resources we need because we live on islands. And so our kids who need residential care actually can't come, they have to leave our island. I live on Big Island, most of the programs on Oahu. And then at some point, they might also be sent to the continent for some kind of service treatment that they can't receive here. And then different formats in terms of who's participating, individuals, that could be the kid alone or even the parent alone at sometimes, groups. So any kind of therapeutic or process groups, or we offer things like psychoeducational groups like DBT. That is something that's also offered in schools, of course, different types of groups. But I will say the ones outside of school can also involve caregivers and other people beyond just the student. And then family therapy. So that looks like a whole slew of different things. One that was mentioned in my bio is PC care. So that's really focused on behavioral management, but it is a type of family therapy. They have ones like multi-systemic family therapy or functional family therapy to address different types of issues. Sometimes with these more intense ones, like with kids with have substance use issues co-occurring with other mental health diagnoses, it's really helpful to have a lot of support for the family in that because they need to know how to respond to the kid. So honestly, family therapy, maybe less of how you might think of it from the movies and more of how you think about it. Like, how can we support the parent in supporting their kid alongside supporting their kid? And then who this is provided by. So private organizations, they can be nonprofit or for-profit. That can look like group practices or just other community mental health organizations funded by different sources, the governmental agencies, that's who I work for, the State Department of Health, hospitals and clinics, they might have both in or outpatient services, and then individual licensed professionals. I think especially now with the accessibility of post-COVID telehealth and all of the things that we've created, made available, it's actually a lot easier for licensed professionals to have their own private practice in a way that I think it wasn't as simple before, but people have been doing this for a long time, right? So you can just have almost like a side gig. It doesn't even have to be a full-time job, but a lot of people who are licensed professionals will also have clients who they see in their private practice. And then often involves care coordination. I think this is a really important and like unique part about community mental health is I can't say this is always the case, but especially when we're talking about youth with higher level concerns, it's important to have someone who's like the central person, the central contact and communicator for the family and for the other people that the family is working with. And so to say a little bit more about the treatment teams and care coordination, these are important collaborative efforts. And this is where part of that overlap between school and community mental health happens. And so I can speak most of the example that I'm familiar with here for the state organization of the Child and Adolescent Mental Health Division. Our treatment teams can be anyone who's going to support the kid, always includes the caregiver, guardian, and the child. And their provider, whoever is directly providing therapy for them. But it can also include a lot of other people. So it can include people from the school, especially if they're seeing also mental health counselor or someone in the school. It can often, if CWS is involved, the CWS social worker will often be a part of the team, probation if they're involved with probation. And then other kind of community support. So here we have things like parent partners and youth partners who are folks with lived experience and a little bit of extra, training who can be there in more informal ways. So I think our parent partner program is actually amazing. It can be a huge support to have someone that's almost like a mentor / friend to really be there as you're going through some potentially very challenging situations with your kids' behavior and emotional well-being. And then the care coordinator, that's that central person I mentioned, or they might be a case manager. In our case, it's often a person with a social work degree, but that's not exclusive. We also have people with counseling degrees or other kind of related degrees who take that on, often like, not necessary, but often they are master's levels. They organize meetings and they have regular check-ins with the family, but they're also just your main point of contact, I think. So when you're a family going through very challenging mental health and things, it can feel very overwhelming to have all these appointments. And imagine having more than one kid who's involved in this kind of treatment, or if the family or community has been through a major trauma. It feels totally overwhelming to know that you have like 7 different appointments to keep up with that week. And it's not that this person is like being your personal assistant, but that person is at least like a go-to who can help you feel more calm and more organized often to help the care make sense for the family and really explain some of those things. Like I mentioned with the 504 and IDAA, that kind of knowledge is invaluable, I think, to help just calm the family and help them feel like all of this is more doable. All right, so there's a few things about access considerations, because as Miranda explained, there's legal systems in place that make sure that the kids who need a certain types of care can get them through these federal, what am I trying to say, standards. And so the requirements vary tremendously place to place, and insurance requirements also vary. So it's so important for providers as they move around to understand how that looks and is different. But sources of referrals often come from physicians, either PCPs or other specialty people, can come from the family themselves, or we get a lot of referrals from school. So like Miranda mentioned, on that tier 2, tier 3, when the school, provides a certain level of care, they might see, oh, this is actually something where they're going to need a lot more support than we can provide them right now, either because of the level of the concern or because the resources available at the school, whatever it is, they'll refer to a community mental health to make sure that they're able to try to access more care. And eligibility criteria can also vary, but in every place, there's going to typically be a specific diagnoses that qualify. So what I mean by that, it's not like we're picking and choosing which ones are, but it's more like there are some that are exclusionary. In my particular situation for where I work, we definitely work with tons of kids with developmental disabilities and autism, but if autism is their primary and only diagnosis and they don't have like clear other mental health going on, or if their developmental disability is such that they wouldn't benefit from talk therapy, then we know we don't have the providers or the systems to support that very well, and they should go somewhere else. And so for us, that can be a non-qualifier if that is kind of the primary diagnosis. But of course, lots of folks with autism also have a lot of other mental health going on. And it may also require a certain level of impairment. So for example, where I work, we use the CAFAS, the Child and Adolescent Functional Assessment Scale, and there are certain cutoff scores. So when we do the eligibility assessment, which I used to do a ton of in the past couple of years, the eligibility assessment, that's the main assessment tool we use. We might also do other rating scales, and a clinical interview is the also main assessment tool we use. And so if they don't have a certain level of impairment, if it's a kid with kind of, still anxiety, depression that would benefit from being treated, that's great. And we would refer them to another community mental health provider. But for the types of services we can offer through the state, there is a higher level of impairment. So there has to be dysfunction in multiple settings and kind of a certain severity. And then other factors to think about, the types of sessions offered. So some places, less so these days, but some places will only do in-person services. Others will offer kind of a hybrid mix of in-person and telehealth. And this can also vary a lot by the type of disorder we're thinking about and the level of severity. Groups may or may not be offered, family sessions may or may not be offered, and the length of service provision. So I don't think this is a very hard and fast rule anywhere that I've been or know about, but typically there's like an average length of what you can expect services to be per a certain given community health center. For us, we tell families and often are between 6 and 9 months of very intensive therapy. So our lowest level of care is multiple hours of therapy a week. It's intensive in-home, which is done in the home or in the community. But that's a lot. It's a lot of therapy. It's a lot, it's kind of exhausting, right? So 6 to 9 months feels like, I don't know if that feels like a short or long period of time, but it is our average. But then we have kids who, of course, are maybe discharged early or will go a lot longer depending on what's going on. And then, of course, there are specialty areas of care. So like I mentioned, with something like eating disorders or neurological concerns that might be affecting the child and family, that's really, really important to make sure specialists are being looped in. So, for example, I worked with a child who had a really intense seizure disorder from the age of like 4 months old, but I was working with her when she was 11. And that seizure disorder was a very confounding factor because I think the school wasn't exactly sure how to best support her beyond some of the basic medical things because her behavioral and emotional issues that were potentially related to the seizure disorder, it was just really complex. And so we made sure to be in contact with the school while we were providing community services and tried to consult with the psychiatrist and the neurologist just to get a better idea of how we can support them because it was so unique to most situations. And that's going to come up a lot with different types of medical diagnosis. It can feel and be very complicated.
Oops. All right. So when we think about the ways that these multiple, very complex systems interact with one another to support youth and their families, there's like clearly a lot happening. And there are some models that tell us sort of what can be beneficial for interprofessional collaboration. The one that, we got some questions first. I forgot about this. Okay, so we'd love to hear why school and community mental health professionals should collaborate based on your experience and how your schools maybe function or have gaps in care. We'd love to hear sort of why collaboration might be important in your setting. And then our second question, which I'll give at the same time in the interest of moving forward in our content, is how is that currently happening? How are school and community mental health professionals collaborating right now in your setting? So why is it important to collaborate? And then how is that happening now? Maybe you've identified some gaps. I know every system that I've worked in that had some collaboration, there were some really, really great assets that are supporting youth, and then also some gaps. So for example,
definitely have an example here for crisis response. So that's a big part of my job now. I work closely with the crisis line. So when you dial 988 or whatever other local number we have, this is an area where there's been a lot of attempts at collaboration, but also conflict because of those things that Miranda mentioned earlier with FERPA, HIPAA. Oh, sorry, we haven't mentioned that yet. That's to come. We're about to talk about FERPA and HIPAA, but because of these legal restrictions on what information can be shared, it can be very frustrating for schools to feel like they're not getting enough information from, for example, the crisis line after a crisis happens, or the crisis mobile outreach folks who go and are dispatched to the place. And that's hard because everyone is just looking out for the same thing. We all have a shared goal of supporting that child and the family. However, because of some of these laws and things that can cause some friction where they're like, why aren't you telling me more things? We're like, we can't tell you more things. So it can be quite difficult when there's a misunderstanding, but I think we have to remember that we're on the same team.
Yeah. I love some of these comments coming in through chat. So community folks in schools can see things differently in ways that are really valuable. There can be some supports to move through both systems from whoever maybe is most trusted by the family. Yeah, schools are limited in what they're able to offer. Of course, we know that workforce shortages are impacting every sector of mental health. And these days, although school mental health and services have expanded greatly, there is in some ways some like shrinking back from that as shortages become more severe and we focus in schools on the things that are legal obligations and maybe hesitate to be able to provide or commit to providing additional services which are gaps that can be filled by those folks who work in the community in mental health spaces.
And those shortages are felt in the community as well. And it usually looks like just a long wait for care. It doesn't mean they won't get care, but it might mean the wait lists are months long, which can be a real problem when a family is like facing a really huge trauma or a huge event.
Absolutely. Okay, so one of the really promising models for collaboration is expanded school mental health. So this refers to sort of the model wherein community mental health providers or outpatient mental health providers can be part-time co-located in a school. So that person may become a member of sort of that school team. They also usually have an office that's inside of the school, and they provide sort of more of the community-based mental health services that Stephanie talked about, but within the school setting. Some great benefits of this model are accessibility. We know that when folks are receiving a high level of care, right? So Stephanie mentioned several sessions a week. That can be really difficult to just coordinate something like transportation to and from. And so expanded school mental health allows for easier access in terms of just making it to an appointment. It also promotes sustainability. I don't have the statistic off the top of my head, but there's a huge increase in follow through on treatment plans when we can increase this accessibility. Schools are already a place that families often see as a community center, as a place that their child is receiving services. And so the extent to which we can sort of build off of that allows us to support students more sustainably over time. Can also allow for continuity of care. So folks who are co-located in a school may be able to enact things like a bilateral release of information, which we'll talk about in a second, that can allow them to more comprehensively collaborate across these systems to support youth in a way that maybe can be more individualized, customized, and a team-based approach. And similarly, we can coordinate across systems when a community mental health provider works specifically with one school or one district. They maybe know more than about how that district works and can guide families in the same way. Folks who work in a particular school who are able to refer to that person who's co-located in their school, they often know the referral process, and they can help streamline what that system looks like rather than sort of sending families into the ether to like make contacts or call someone that they find on Google. We can do a lot more of that warm handoff. Some of these, some best practices also include alignment and role clarification. So we know that there's some overlap, particularly in things like behavior and depression, anxiety type of things that can be supported for youth in schools and in outpatient mental health settings. So it's important for us to, as we're thinking about systems and initiating partnerships, to sort of think about the needs assessment and resource mapping strategy. There's some resources from the National Center for School Mental Health in the resource guide that accompanies this webinar that has some information about needs assessment and resource mapping, which really refers to the act of taking stock of what all is available and identifying gaps and overlap to streamline maybe where there is overlap, whose job it is and in which situations something's managed within the school or outside of the school. And then with gaps, maybe who's best situated to respond to those needs. When we do our needs assessment and resource mapping, we can avoid duplication by identifying synergistic opportunities. For example, if there's something that maybe is already being provided, we can link up with that support rather than duplicating it. I know with sort of increased attention towards grant funding in school-based mental health services, there has been some maybe recreating of the wheel among some schools and districts and partners where maybe something already exists in the community that we can support and facilitate and enhance rather than duplicating. Then it's important that as we understand sort of our referral pathways and who we collaborate with, to delegate and coordinate based on unique skills and strengths and also availability. We've been talking about shortages. And so of course, sort of system capacity is important to consider here as well. For communication planning, this is a really big piece, particularly when we think about what information gets shared and is known across systems. So if we've got a school and a community agency partnering, it's important for us to have a leadership team that has diverse invested parties, right? That includes folks who have been served by these different resources, that includes folks who are part of the eligibility determinations, who are part of the service provision among these different maybe care coordination opportunities among these different agencies, so that we can sort of understand how all of these things work together. So having sort of a leadership team that is intended to support that care collaboration is really critical. Then we want to identify a liaison for partnering organizations, just to have a point of contact, because often in the school, there are like 10 people who are involved in care. In an outpatient setting, there are 10 people who are involved in care, and it can be helpful just to centralize some of that communication, so we again avoid duplication. And then we want to make sure that we make plans about communicating, identifying sensitive or private information. I mentioned before that when we have expanded school mental health, something like a bilateral release of information can be really helpful. It's important to think about the ways that we're going to document and share information on the front end, so that we're planning for what will happen rather than reacting when we're in a crisis situation and need to communicate something and don't know how we can sort of maintain our legal and ethical standards while doing that. And some federal law that guides some of this is FERPA and HIPAA, which Stephanie will tell us more about.
All right, so FERPA, the Family Educational Rights and Privacy Act, and the HIPAA, the Health Insurance Portability and Accountability Act. Bit of a mouthful, so the acronyms are better. On the next page, we have 2 pages. There are some tables, which again, probably a good resource from the handout more than me looking at right now, but I'm going to give a big picture overview of the difference. So FERPA, if you're a school-based person, this is something that you are more familiar with, I'm sure. It's a federal law from 1974 that's really to protect the privacy of student education records. And it prohibits people from, disclosing personally identifiable information without written consent, and it gives parents and students more control over their educational records. And so all levels of education comply with that. Whereas HIPAA is a national standard about private health information. So that's any kind of health care stuff you do that is protected by HIPAA. And the main goal is to make sure everyone is, their information is protected while allowing a flow of information needed for care. And that is the people who comply with that are more in the healthcare sector. So that's mental health care and physical health care alike. You can see on the protected information for FERPA, next page, is the student education record versus the protected information for HIPAA is your identifiable health information in any form. And that covers a lot of things like your address and your name and everything like that. So this is excluding certain educational employment records. And those are the folks on the right side who you're permitted to disclose to. So school educators, that's part of the friction of that crisis communication thing we're having, is school folks are used to communicating with other school folks about the things that need to be communicated about for care, right? That's part of FERPA, is being able to communicate with other school officials, to different schools, appropriate parties with financial aid, all that. Whereas the folks with HIPAA they don't have the same that kind of flow with FERPA. So there does not, like Miranda mentioned, a release of information is really important because it's pretty restrictive on what you are allowed to say. And different folks will even have even more conservative interpretations of HIPAA, depending on who is your, privacy officer. And so there's limited data available that's for research, public health, or healthcare operations. There's large data sets for any of you who are researchers, but also there are ways that hospitals will de-identify things and have certain data banks that the information will go into for people to look at who are permitted for already de-identified information. But this is often for that public health interest, right? We're trying to make research available without having any personal identifying information. So understanding the differences between these and kind of where you might fall in what you're required to do. If you're required to do either of these, I'm sure you have to go through multiple trainings about this. We for sure have to do HIPAA refreshers every year, I think. And I haven't been in the school system in a while, but I know that they have to learn about FERPA in a similar way.
Yeah, so it's really important that we sort of coordinate care and that we are intentional about sort of the building blocks of who does what and sort of how things happen. We hope that this sort of broad overview and primer on who does what in schools and out of schools has been helpful to you, or is something that you can potentially share once the recording is available with folks who may not be aware of the sort of nuances or the different roles across these systems. We now have about 5 minutes for any questions and questions you have to chat about, or any comments or wonderings or case examples, anything that sort of is top of mind as you think about coordinating care. I'm glad this is helpful. I know that it's having sort of until about 2 years ago only worked in schools, and then suddenly being on the community partner side of things, it really helped me get some insight into sort of what is known and not known about these different entities. And so I hope that sort of passing on some of that intersection can continue to be helpful to you, particularly as you help families navigate complexities. We know that there are a lot of things that we can do in schools, a lot of things that we like to do in schools. And it's families don't always know what their sort of schools are obligated to provide to them. Okay, someone's wondering if they need to know about a school district's gaps and needs before proposing a co-located shared therapist from a community mental health organization. I think best practice would probably be to figure out sort of what's happening in that school now and the ways that students are being supported and how that can be expanded. I'm willing to bet that if you worked with that school and identified some gaps, there would be things there. It's also, I think, really important to think about, as you're thinking about expanded school mental health, what co-location looks like and what funding looks like in particular. So there's some models that can be grant funded, that may allow for some supports and services at that tier 2 or group intervention level that families maybe don't have to pay for, or that insurance doesn't have to be billed for. You might also be able to co-locate and bill insurance or Medicaid. I know the model that I worked under in Baltimore City had a contract with the outpatient provider that I worked for. And so about 50% of my time was paid for that sort of systems level tier 1 and tier 2 service. And then 50% of my time was reimbursed through Medicaid billing. So there's some kind of crafty ways that you can think about or explore what funding looks like that can help you plug in and support schools in the ways that they might need. And there might be some ways to creatively fund that that would really require. Yes, you can share anything. This recording will be up and publicly available. I think that Jen shared the link before. Please send to as many people as you think could learn from this.
Are there any other additional questions? We have just a quick minute. All right. Well, thank you, both Miranda and Stephanie. We appreciate this so much. And so to everyone, I just put the where you can find the slides and resource guide in the chat again. Additionally, please check out the first webinar of this series. It's Collaboration for High Quality School Mental Health Services, Effective Partnering with Families and Advocates. I just put that in the chat. You will be automatically redirected to a very brief survey. We greatly appreciate you taking a moment to fill that out. It's how we are able to continue providing these free trainings to you all. So they are very much appreciated and valued. Please check out our upcoming, we've got a lot of great upcoming events coming up on through the Great Lakes MHTTC. So please check that out too, our events calendar. And we hope to see you again soon. Just putting the events calendar back on in the chat as well. All right, thanks again, and we hope you have a great rest of your day. Bye-bye.
Thanks all for
everyone.
joining.